Hello dear students, once again come to my channel. So we are discussing about congenital heart disorders. Already I have started with the acyanotic congenital heart disorders. In that one we have already discussed about atrial septal defect and ventricular septal defect. So today I am going to discuss about third acyanotic congenital heart disease, that is patent ductus arteriosus. Okay, so let's discuss about the patent ductus arteriosus. First definition: patent ductus arteriosus is an abnormal communication between the pulmonary artery and aorta. Okay, so this is a, see here, this is aorta and this is a pulmonary artery. So here you can see there is a abnormal communication. Okay, you can see this is a abnormal communication. There is abnormal opening between the aorta and pulmonary artery. Okay, so this is a abnormal communication. Okay, which is known as a patent ductus arteriosus. Okay, actually ductus arteriosus normally present during the fetal life. Okay, but once the birth of the baby happens, once the birth of the baby takes place, within 2 to 3 days it's supposed to close. Okay, this abnormal ductus arteriosus supposed to close after 2 to 3 days of birth, but when it remain open and does not close, so this condition is known as a patent ductus arteriosus. Okay, so what is patent ductus arteriosus? So this patent ductus arteriosus definition, it is an abnormal communication between the aorta and pulmonary artery, in which there is a shunting of blood from high pressure in the aorta to the low pressure in pulmonary artery, which results in shunting of blood from high pressure in the aorta to the low pressure in the pulmonary artery. Now, what are the incidents of this patent ductus arteriosus? This patent ductus arteriosus is most commonly found in preterm infants. Okay, the infant which is born before 37 week of gestation, they are known as a preterm infants. Okay, it is also commonly found in low birth weight. The baby whose weight is less than 2.5 kg, the birth weight is less than 2.5 kg, they are known as low birth weight. So this PDA is most commonly found in low birth weight. Next, this PDA is also found in female baby. It is most commonly found in the female babies. Okay. Now, what are the etiological factors? Okay, etiological factors are same like the etiological factors of ASD and VSD. Same common etiological factors, that is genetic and chromosomal abnormality. So this patent ductus arteriosus is most commonly associated with chromosomal abnormalities such as Down syndrome, Turner syndrome, Klinefelter syndromes. Whenever there is a chromosomal abnormality, there we can also suspect patent ductus arteriosus. Next one, teratogenic infection. When infection that happens to the mother during the first trimester of pregnancy, teratogenic drugs, when mother takes any teratogenic drugs like thalidomide during the first trimester of pregnancy, that can result into patent ductus arteriosus. Alcohol consumption during pregnancy, if mother takes excessive alcohol during pregnancy, that can give rise to patent ductus arteriosus. Maternal insulin dependent diabetes mellitus, that is type 1 diabetes mellitus, if mother develops, they are at risk for developing a giving rise to baby with a patent ductus arteriosus. Birth asphyxia, when baby is unable to establish breathe after the birth, after taking birth, then it is known as birth asphyxia. Fetal hypoxia, that is decreased oxygen supply to the fetus during pregnancy. So these are all the factors, etiological factors that are contributing for the development of patent ductus arteriosus. Now let us see what is the pathological physiological changes. Pathophysiology. So what happens here? Due to any of etiological factors, the baby will develop a patent ductus arteriosus, that is abnormal opening or communication between the aorta and pulmonary artery. So because of this, what happens here? There is shunting. Okay, there is a shunting of blood from high pressure. Okay, from high pressure in aorta to low pressure in pulmonary artery. So because of this abnormal communication, the blood will move from high pressure in the aorta to the low pressure in pulmonary artery. Okay, so because of this, what happens here? There is increase pulmonary blood flow. So this will lead to increase pulmonary artery capillary pressure. This will increase pulmonary artery capillary pressure. So this will lead to forcing of fluid. Okay, forcing of fluid, forcing of fluid from pulmonary artery capillary to alveoli, and alveolar structure. So this will lead to what happens here. So when there is a fluid will shift from force from alveolar and alveolar structures. Okay, then there is a leakage of fluid into alveolar and alveolar structures. Okay, that condition is known as pulmonary. Okay, the child will develop a pulmonary edema. So this pulmonary edema will show recurrent respiratory tract infection. Okay, so this is the one-sided pathophysiology. So what happens here, due to etiological factor, okay, there is a abnormal communication between the aorta and pulmonary artery, that is known as patent ductus arteriosus. So because of this, what happens here, the blood will shunt. Okay, there is a movement of blood from high pressure in the aorta to the low pressure in the pulmonary artery. So because of shunting of this blood from aorta to the pulmonary artery, there is an increased pulmonary blood flow. So increased pulmonary blood flow. Okay, this increased pulmonary blood flow leads to what happens here, there is increased pulmonary artery capillary pressure. Okay, there is more pressure over the pulmonary artery. So this will lead to what happens, there is a forcing of fluid, okay, or diffusion of fluid from pulmonary artery capillary into the alveoli and alveolar structures. So this will give rise to pulmonary edema, and pulmonary edema will lead to recurrent respiratory tract infection. Okay, so this is one-sided pathophysiology. Now let us see what is another pathophysiology. So next pathophysiology is due to etiological factors. There is a patent ductus arteriosus, that is structural defect. This patent ductus arteriosus will lead to what happens here, shunting of blood. Okay, shunting of blood from aorta to pulmonary artery. Okay, so due to etiological factor, there is structural deformity, that is patent ductus arteriosus. This leads to shunting of blood from high pressure in the aorta to the low pressure in pulmonary artery. So because of this, what happens here, there is increased resistance. Okay, there is increased resistance in right ventricle for forward movement of blood. Okay, because there is a back flow of blood, there is obstruction of forward flow of blood from right ventricle into the pulmonary artery. So because of this, what happens here, the pressure and volume of blood in right ventricle increases. Okay, so because of shunting of blood from aorta to the pulmonary artery, there is increased resistance in right ventricle in forward movement of blood or forward flow of blood. So this will lead to the pressure and volume of blood in right ventricle increases. So this will lead to what happens, this will lead to right ventricular hypertrophy and hyperplasia. That will lead to right ventricular hypertrophy and hyperplasia and right ventricle enlargement. Okay, so finally it will lead to right ventricular enlargement. So this will continue it will continue now still. So there is a right ventricular enlargement, and because of increased pressure in the right ventricle, and right ventricle enlargement, what happens here? So this right atrium is unable to empty the blood completely into right ventricle. So right atrium is unable to empty the blood completely into the right ventricle. However, the blood coming to the right atrium through the superior vena cava and inferior vena cava is same quantity, but right atrium is unable to empty the blood completely into the right ventricle. So because of this, what happens here, pressure and volume of blood in right ventricle also increases. So because of this, what happens here, right atrial hypertrophy and hyperplasia takes place, and finally right atrium enlargement will take place. So when right atrium is unable to empty the blood completely from right atrium to the right ventricle, so pressure and volume of blood in right atrium increases. Finally, it will lead to right atrial hypertrophy and hyperplasia and right atrial enlargement. So finally, what happens here? There is a back flow of blood. Okay, back flow of blood from right atrium to superior vena cava and inferior vena cava. So this will lead to, finally it will lead to peripheral edema. Okay, so this will give rise to finally peripheral edema. So this will result finally into peripheral edema. So just have a glance of this pathophysiology. So what happens here? Due to etiological factors will lead to, it will give rise to patent ductus arteriosus, that is special defect. So because of this, what happens here? Shunting of blood from aorta, high pressure in the aorta to the low pressure in the pulmonary artery. So because of this shunting of blood from aorta to the pulmonary artery, there is increased resistance in the forward flow of blood from right ventricle. So because of this, the pressure and volume in the right ventricle increases, and finally it leads to right ventricular hypertrophy and hyperplasia and right ventricular enlargement. Then what happens here? Right atrium is unable to empty the blood completely into the right ventricle, and the pressure and volume of blood in right atrium also increases, and right atrial enlargement will take place. Okay, there is a right atrial hypertrophy and hyperplasia and right atrial enlargement. And finally, because of high pressure in the right atrium, there is a backflow of blood from right atrium to the superior vena cava and inferior vena cava. It will lead to peripheral edema. Okay, and last pathophysiology, last one. So due to etiological factor, there is structural deformity, that is patent ductus arteriosus. So this will lead to shunting of blood. Okay, shunting of blood from aorta to pulmonary artery. So because of shunting of blood from high pressure in the aorta to the low pressure in pulmonary artery, this what happens here? There is decreased stroke volume, decreased cardiac output, decreased peripheral tissue perfusion. And this will lead to failure to thrive. So why there is a decreased stroke volume and cardiac output? Here, what happens here? Though the blood comes adequately to the left atrium and left ventricle after the oxygenation is there is no problem in oxygenation and there is no problem with the pulmonary blood flow. But once left ventricle contraction happens, no, the blood is emptied from left ventricle into the aorta, but the blood will not move further. So the blood, some amount of blood will be shunt. Okay, that is transmitted to the pulmonary artery. So some amount of blood transmitted to the pulmonary artery. Okay, so because of this, the less amount of blood go for the peripheral tissue perfusion. So overall, it will lead to decreased stroke volume, decreased cardiac output, and decreased peripheral tissue perfusion. Okay, so to tell about the pathophysiology. Okay, so third pathophysiology is due to etiological factors. There is patent ductus arteriosus. So this patent ductus arteriosus will lead to shunting of blood from high pressure in the aorta to the low pressure in pulmonary artery. Okay, so during the contraction of left ventricle, what happens here? Though the good volume of amount is ejected from left ventricle to the aorta, but because of this ductus arteriosus, patent ductus arteriosus, the some amount of volume of blood is again go back to the pulmonary artery, and that will lead to decreased supply of blood to the peripheral tissue perfusion. Okay, so that is why there is a decreased stroke volume, decreased cardiac output, and decreased peripheral tissue perfusion. That will lead to failure to thrive. The baby is unable to attain adequate height and weight. Now let us see what is the clinical manifestation. Clinical manifestation. Okay, there will be same clinical manifestation like how we have discussed in the ventricular septal defect. That will be like the child will have dyspnea, tachycardia, tachypnea, shortness of breath, failure to thrive, failure to thrive. Then there will be peripheral edema, recurrent respiratory tract infection. Okay. So dyspnea is nothing but difficulty in breathing, tachycardia, increased heart rate, tachypnea, increased respiration rate, shortness of breath, it is because of pulmonary edema. Okay. Then failure to thrive, it is because of decreased peripheral tissue perfusion and recurrent respiratory tract infections. Okay. So these are the clinical manifestation of patent ductus arteriosus. Okay. So clinical manifestations are almost same like a ASD and VSD. Okay. So we will discuss about the diagnostic evaluation in a next video. Okay. This is a part 1 video of this one. Thank you.